Hello, my name is Nicole Thorson. I'm the BOI manager for North Carolina, and I'm here to talk about the Physician Medical Record Review, or PMRR program. We will look at the goals of the PMRR program, responsibilities of reviewers, estimating the number of reviewers for the market, the training and support that is provided, and the reviewer incentive. We will also briefly go over the PMRR process. The goals of the PMRR program are to improve documentation within the medical records, reflect accurate disease burden for patients, remove or clarify inaccurate ICD-10 codes used by providers, improve PCP understanding of the ICD-10 coding logic, provide recommendations for additional services that drive quality care, suggest referrals to care management for the most complex patients, and present consistent recommendations based on clinical guidelines. The physician reviewer's main responsibility is to perform prospective chart reviews for patients prior to their scheduled eligible visit to determine whether there are known significant or chronic conditions yet to be assessed, as well as any potential new conditions. To accomplish this, reviewers will review medical histories, labs, images, and more, and then place their observations into the HCC Manager system, also known as CORE. These suggestions will be combined with the previously diagnosed conditions to generate a member information profile, also known as a MIP, to provide notification to the treating clinician. The clinician, based upon a face-to-face visit with the patient and using their clinical judgment, can either accept the suggestions and document the conditions in the medical record or decline and state why. Additional reviewer responsibilities include undergoing and passing inter-rater reliability testing every 2 years to ensure consistency in the chart review processes, as well as between physician medical record reviewers. Reviewers also attend review trainings, education sessions, and materials provided by Agilon. Reviewers serve as subject matter experts for providers in the community, and also are sure to follow the ICD-10 coding and documentation guidelines. Agilon has developed a formula to estimate the number of physician reviewers that a market may need. For this model, we will make the following assumptions. Physician reviewers will commit at least 3 hours per week. Physician reviewers will perform record reviews for at least 42 weeks per year. Reviewers will review between 3 and 5 charts per hour once they are fully trained and comfortable. The formula also looks at the market's goals for AWVs to complete in the year, as well as the market goal for how many patients that have a scheduled AWV that are expected to have a chart review completed. For these two numbers, I used Wilmington Health's goal of 80% in this formula. So using the estimated number of patients for Pinehurst of 8,000, the visit rate and chart review goals from Wilmington Health of 8% each, and the reviewer time commitment numbers from above, it is estimated that Pinehurst will need approximately 9 to 11 reviewers. The training and support provided, there's initial training that is presented over a 2 to 3 hour period and held prior to the BOI program launch. The physician chart reviewer will be provided with education and training related to burden of illness, HCC coding and documentation, and the HCC Manager system. Reviewers will also have direct access to support within Agilon Health for any questions related to coding, as well as for the tools that are provided. The BOI program manager will also establish and facilitate ongoing PMRR meetings for reviewers. During these meetings, we look at year-to-date progress of key performance indicators, review clinical and PMRR guidelines and updates, review and answer any questions from reviewers or PCPs, and provide any additional information and education. The PMRR meetings are typically about an hour in length. These are initially held on a weekly basis, but may change to bi-weekly as the program matures. Regular case studies will be conducted and reviewed at PMRR meetings as well. These allow physician chart reviewers to see how they are doing both individually as well as a group, and also receive feedback on their reviews. The physician medical record reviewers are compensated for the hours they spend completing chart reviews, reviewing case studies, and for the time spent attending trainings and PMRR meetings. Reviewers keep and submit timesheets on a monthly basis to the BOI manager. The BOI manager also maintains an attendance and timesheet log for trainings and meetings. Each month, the BOI program manager will calculate the total hours dedicated to the program for each reviewer and submit to Agilon's accounting department for payment. The payment rate is still to be determined and is based on fair market value. The following slides are an overview of the actual PMRR process, including what the process includes for reviewers, as well as the types of suggestions reviewers make and when to use each type. This process will be reviewed in depth during the initial PMRR training. The current PMRR process includes indications for chronic conditions assessed in previous years that have not been submitted in the current year, review of medications and durable medical equipment ordered for the member to determine if correlating diagnoses have been submitted, review of acute conditions that were submitted to CMS for a previous year and submitted in the sequential year that no longer apply, review of conditions that were reported at an office or outpatient setting that are usually submitted via inpatient claims to check for validity and to indicate suppression or deletion of a condition when appropriate. And also to review all cancer diagnoses that were submitted to ensure the condition is still active and indicate when a history of code may be appropriate. Documents that are included in the review process are past medical records to gather prior diagnoses, lab, diagnostic radiology, consultations, and all other pertinent documentation that provides a profile of the member's past conditions, and current medical records and claims data to ensure previous year's chronic conditions are being brought forward with proper documentation. Reviewers are encouraged to use specific ICD-10 diagnosis codes when there is strong evidence to support that diagnosis in the medical record. For a physician reviewer without the patient in front of them, the evidence for recommendations must be supported in the medical record. Often, the recommendation from the PMRR is to clarify an ICD-10 code to a higher level of specificity. For example, diabetes without complications changes to diabetes with nephropathy, or colon cancer changes to history of colon cancer. Clinical findings can be found in both outpatient and inpatient medical records. When suggesting an ICD-10 code, reviewers should indicate where the evidence was found in the medical record to help the documenting physician easily locate the information and to support the diagnosis. Physician reviewers are also able to make suggestions to PCPs that are not ICD-10 diagnosis codes. These 4 suggestions listed, EDU, REC, ADX, and none, are the most common other suggestions used. EDUs are educational comments, informational messages, or suggestions for other diagnosis codes. It can be used when an ICD-10 code may have been used inaccurately or when questioning a diagnosis. For example, the normal PFTs on record are not consistent with the diagnosis of COPD in the problem list, and the patient is not on medications. Or remove the diagnosis of acute stroke in the problem list and evaluate for sequela of the CVA. RECs are used to communicate recommendations for testing and treatment, procedures, or evaluation for new or undocumented conditions. This is how additional studies are suggested or when additional exam and history is recommended to clarify a diagnosis. For example, patient has a 30-year smoking history, consider PFTs, or patient on Celexa without a diagnosis. Is this major depression? ADXs are used when recommending a diagnosis that is in the same HCC category as another diagnosis that is already indicated on the MIP or captured. When a duplicate HCC category is suggested, the MIP logic will suppress your recommendation. Suggesting the diagnosis as an ADX allows both diagnoses to be presented to the provider. For example, aortic aneurysm is found on CT, and peripheral vascular disease is already documented. Both of these diagnoses are within the same HCC category of 108, but you want to communicate the AAA to the PCP. Finally, none should be used when the chart is reviewed and there are no additional clinical suggestions to be made. This concludes our brief overview of the Physician Medical Record Review Program and processes. If you have any questions or concerns or would like to discuss the PMRR program or processes in more detail, please do not hesitate to reach out. I've included the emails and phone numbers for the Pinehurst Market team, which includes myself, the BOI North Carolina manager, Ryan Smith, the market president, and Trip Cothran, the director of new market implementation. Thank you.